So let's speak English now.
This is a clinical case of biliary obstruction in a liver sector. And the title of the communication is 5 years follow-up is not enough. Part one of the clinical case is 2010, 63-year-old woman, sigmoidectomy for adenocarcinoma PT3N1 in 2004, and she was referred in 2010 at my consultation for a suspected intrahepatic cholangiocarcinoma. The performance status was OMS 0, biological cholestasis, nothing else, CAA normal, and CA99 70. I show you the selected CT scan and MRI images. This is in June, the 3rd of June 2010. So you can see here the scan with dilatation of the segment 8, a little bit segment 5, and material in the biliary tract. This is another view, a coronal view. You can see the main biliary tract here is normal, the portal vein, and here is the dilatation and the mass, a little mass here and here in the bile duct. And also here with the mass, you can see here, and biliary material. Another view rapidly, you can see here also. This is the MRI, few days after, and it's quite surprising because we don't attempt such reconstruction because the stenosis is relatively high here, and this is the material in the biliary tract. So what is your opinion now? Cholangiocarcinoma, biliary papillomatosis, but remember that 6 years before, in 2004, the patient had a sigmoidectomy for PT3N1 adenocarcinoma. So the last possible diagnosis is intrahepatic biliary metastasis, which is a very rare case, but it's possible. You want to discuss the diagnosis? Can come back to the imaging.
Thank you very much, Jean-Robert. I leave the floor to anybody who would like to speak, otherwise I'll speak.
So Pietro, the biliary papillomatosis, as called, is now IPNB. I think this is a very likely differential diagnosis. So I would raise IPNB as one of the differentials.
Yes. Against that, for me, is that it is very focal and the dilatation seems to be progressive. So for me, this is intrabiliary metastasis, which we had maybe because of a bias, because we had recently a very similar case, which we missed for 3 months, and then the penny dropped. So my bet would be the intrabiliary metastasis.
All right, but you know that biliary intrametastasis mimic very often cholangiocarcinoma or papillomatosis, intrabiliary papillomatosis. Okay, yes. We move on. So,
but you can biopsy it.
I don't do biopsy. Perhaps I am wrong, but I don't do biopsy. I send a letter to the gastroenterologist and I said, the imaging data may suggest cholangiocarcinoma, also papillary biliary, but of course, given his history, I raised the possibility of an endobiliary lesion secondary to his colonic adenocarcinoma operated on 6 years ago. What is now your decision? Biopsy, perhaps, but what do you do?
Could we see the images?
Laurence
Well,
raised her hand.
I think that whatever the diagnosis, the decision is the same. There is, I think that both diagnoses are possible, IPBM or intrahepatic metastasis, but this is exactly the same operation for me. So I perform surgery.
Yes. Same for me. It would be elegant to have the biopsy before, but it's not mandatory.
No.
All right.
René is thinking very loud.
I think the same. I think for me it could be a metastasis with intrabiliary propension, or I would say sort of papillomatosis. But for me, it's a biliary tumor, intrabiliary tumor. So this is
John
clear.
has raised his hand.
I agree surgery is the approach, but I think it would be a little bit different if we had IPNB or, we would have to stage and consider a wider biliary resection. And if it was intraductal met, then it'd be treated with a standard resection, I believe.
In this case, I think the resection would take away all the right system, whichever.
Yes.
And I can't see any abnormality on the left biliary system, which admittedly has to be investigated or seen better.
So I agree.
There is also, just to comment, there is also dilatation, it seems, of part of the left duct. If I see, could you come back to the images for me, either of the segment 4 or the left bile duct? No, I think this is.
I thought it was quite normal. On the cholangio MRI, I thought it was quite normal.
It could be the anterior sector that is dilated. It could be.
Yes.
Okay.
Okay, so I agree with the majority of the discutants. And after a portal embolization in July, because the patient had 12 cycles of chemo after the colon resection because of the N1, and I plan to do rapidly a right hepatectomy. The standard resection, this is the operative view with the peroperative ecography. And at the end of the resection, the cholangiography was strictly normal. The pathology report is biliary ductal location of an adenocarcinoma whose histochemical profile was CK7 negative and CK20 positive, and is more in favor, because of the immunohistochemy, of the secondary lesion of the already known colorectal adenocarcinoma than a possible transformed biliary papillomatosis. This biliary endoductal tumor presents necrotic changes. It remains strictly intraductal without infiltration of the adjacent hepatic parenchyma. The margins were negative and the resection was considered as R0. Immunohistochemy is one of the key of the diagnosis, because CK20 positive and CK7 negative is very important finding. And you can read in the paper, in the recent paper of Onishi, a Japanese paper, that as this metastatic disease mimics cholangiocarcinoma, often mimics cholangiocarcinoma, they were in this paper unable to differentiate before resection. And the definitive diagnosis of metastatic colonic carcinoma could be attributed to the immunohistochemistry. This is the same of our case. The mechanism in this other paper, very recent paper, you can see here the Henri tumor. This is the histology, and the authors suggest that the mechanism, which is very discussed, the mechanism of intrahepatic bile duct metastasis, cancer cells may spread from the primary via the portal circulation and implant in the bile duct by passing through the peribiliary capillary plexus. So, post-operative course was uneventful. Post-op chemo, Folfox-Avastin, 12 cycles, so more chemo. And in November 2010, 4 months after resection, this is the CT scan, which is considered as normal. This is an hemangioma in the spleen. And we decide to follow the patient every 4 months during 2 years, every 6 months until 2021, owing that this disease may recur very late. And a recent paper published in BMC Surgery shows such a case with a recurrence 12 years after the resection. In October 10 years after, all was okay in October. You can see here the CT. This is the portal vein, okay, no problem. The scan was considered as strictly normal. 6 months later, in April 2021, the patients recurred. This is the part 2 of the clinical case. So April 21, 2021, performance status is always OMS 0. She complains of pain in the right upper quadrant. Biology was strictly normal, except the CEA, which is 12.8, and she is referred before her scheduled consultation with an ultrasound showing a 3.5 by 2 centimeters mass in segment 1. And these are the imaging. You can see the mass progressive here, the mass in the segment 1, contact of the left branch of the portal vein and the vena cava. This is another view, and this is another view. And here. So the mass, the diameter is 50 by 37 millimeters diameters, and with a huge vascular contact with the left branch of the portal vein and the vena cava. No other lesion. The thorax is normal, no lymph nodes, no suspicion of carcinomatosis, peritoneal carcinomatosis, and we have to take a decision. This is another view with the CT here. Here you can see the cut surface of the liver here, the suprahepatic vein here. MRI, a few days after, this is the MRI.
Laurence, do you want to say something now? Or shall we wait?
I just want to ask Jean-Robert if this patient had a regular follow-up.
As you can see here, every 4 months during 2 years and every 6 months until 2000, during 10 years.
So I guess that 6 months before there was nothing.
Yes.
And now she has this CT because she is symptomatic.
Yes, I'm very surprised. And the scheduled consultation was few days after the gastroenterologist see the patients and does an ultrasound, discovering
Okay.
in the interval of the two follow-ups.
So it is rapidly progressive.
Yes, very rapidly progressive.
Yeah.
So
Hugo's raised his hand.
you need to do some chemotherapy.
Yes.
Hello, good morning, everyone. Sorry to be a little late. I was in another meeting. I think this is a very interesting case, and also raises another question, which is whether we should continue to do the regular 5-year follow-up in some of those patients, or we should extend to 10 years in particular cases such as this one. I think in liver metastasis from colorectal cancer, I think we will have this problem more and more, and probably 5 years is not enough.
Hugo, this is the title of my clinical case. 5 years is not enough. And in my department, the rule is 10-year follow-up.
I agree.
So you start with the conclusion.
And it's terrible because a recent paper show a recurrence 12 years after the resection, the hepatic resection, the first hepatic resection. So now we are in 2021 in April, and you see the MRI here with this huge mets in contact of the left pedicle.
Jean-Robert, just one thing.
Yes.
Did you consider candidacy for liver transplantation in this patient?
Hugo, just a second. There are people raising their hands,
Sorry.
like Laurence and Gina first.
I continue the imagine. If you this is the recurrence, this happened in the interval between 2 consultations. 6 months before, there was nothing. All was the patient is very well again, but and the only biological anomaly is the elevation of the CE. So another view here. So clinical status, OMS 0, no pulmonary nodule, no peritoneal or lymph node dissemination. What is your decision now?
Right, Laurence and Gina has raised their hands, and Hugo afterwards.
Gina, perhaps first.
Okay, thank you. First point to Jean-Robert. I don't understand who decided and by which criteria they decided to stop follow-up after 5 years. In my personal view, specifically in colorectal cancer and metastasis, definitely you don't stop the follow-up. That's my first point. So I agree with you. You should continue. In my personal view, it's for life. So this is the first thing. Second thing, as you showed in your clinical case, and I like that because you showed that it was the elevation of CEA, and sometimes this is the first sign. If the CEA is always stable and you can see even if it's normal and it increases by 1 step, you should be worried because there is something happening. So when we say follow-up, it's this whole package, and it shows that cancer, colorectal cancer is for life, so don't stop the follow-up. Third point for this specific case, I think there's a big room for neoadjuvant chemotherapy because it is in segment 1. Before thinking about liver transplant or anything, I think there is a room for segmentectomy or more economic liver resection, and I would start with neoadjuvant chemotherapy. Thank you.
Yeah, thank you. Gina, Laurence?
I will be provocative. I do not agree that all patients with metastasis should be followed 10 years or at life, because you know that it is not so frequent to have those very late, and economically it's not possible. But here, I'm sorry, but follow-up was not useful because she became symptomatic, and she is not she has not the benefit of the follow-up since well, she was symptomatic. So I don't agree with this follow-up all lifelong because again, it's not it's not realistic. But for this patient, as I said, it is a recurrence, late recurrence, but progressive one. So maybe, well, maybe you should do a biopsy before, but I don't know if it's really useful. But doing chemotherapy is the first step to reduce the mass and then bring them to surgery.
Yeah, thank you, Laurence. To take the messages of the follow-up, I think we should investigate the previous X-rays and see whether the follow-up was interpreted all right. I think we could learn from that. Ugo.
Yes, just saying that I agree with all the commentaries, and I think that although when looking at the images at this point, we could think that he could be a candidate, whether for a resection eventually with vascular resection or retransplantation. At this point, I think it is mandatory to perform chemotherapy again.
All right.
Prashant?
Yeah, thank you. I think, of course, I agree with neoadjuvant chemo first. I just wanted to raise a point whether this excellent case demonstrates the fact that if there is a lesion in the biliary tract, and even if you're resecting by doing only a right hepatectomy, whether it should always be accompanied with an extension and excision of the caudate, a resection of the caudate. Because if you see here, the recurrence is happening only in the caudate duct. There is no other recurrence anywhere in the liver. So whether, even if you were doing a right hepatectomy and you were clear of the margins, a caudate resection was required first stage itself.
Arguable, but we may discuss about that. René, would you like to take, so the consensus is chemotherapy and there is room for a resection.
No,
and I think personally there is room for a resection of the segment 1 in this patient.
I fully agree. Neoadjuvant chemotherapy is absolutely mandatory because it's a very quickly progressive disease, despite the fact that the recurrence was very, very long after the colon resection. But anyway, I would say chemotherapy is mandatory. Now there is two possibilities: whether the tumor retracts, I would say, not at the contact of the vessel, and it's possible because it is not always, I would say, stick to the vessel. And at that time, I think segment 1 resection would be curative. Or the other possibility is that the tumor decrease in size, but remain at the contact of the vessel, of the vena cava and of the portal vein. And at that time, I think we will go to R1 resection, and the alternative could be transplantation in this relatively young patient with a long history of colorectal cancer. But I would prefer, of course, to do resection if a possibility of R0 resection is possible.
Yes.
If you want,
Robert?
Yes, I continue. So we performed 6 cycles of FOLFIRINOX. August, CER was normalized, and there is a response on CT and MRI. And you can see here a little space between the portal vein and the tumor, which is 20 millimeters versus 50 millimeters. Another view with the margin with the vena cava here. And you can see here the left liver with the small dilatation of the left side, 7 millimeter diameters. So what do you plan now?
For me, it would be a resection of segment 1 and the biliary reconstruction. I would resect the bile duct at this moment and do like anastomosis on the joining of segment 2, 3, 4. I don't think you need to resect the portal vein. I still think that this tumor is developing endobiliary.
Okay. Another opinion? So I move on. Pietro?
No,
Okay.
John.
John?
Just to say, the behavior of a MET in the colorectal cancer metastasis of the biliary tree is not something that we're very familiar with in terms of the need for resection of bile duct. But I agree with you, Pietro. This is demonstrating more behavior like a cholangiocarcinoma, even from the beginning. And that comment about taking segment 1 might have been valid even at the beginning. But I think now it's proven to have that behavior. And I certainly agree a biliary resection is indicated at this point in time.
Yeah.
Okay.
Jean-Robert,
Oui.
just another question. From the beginning, I think it's very important to consider now the
Il y a un micro qui perturbe le... This is a microphone with a sound
On
permanent.
entend de la musique, il faudrait couper tous les
The violin music.
The doors. It's my daughter. I close all the doors.
okay. The
Carry on.
molecular profile of this tumor in the beginning and where was located the primary tumor, in the right column or left column. I think that information is interesting to follow up and to decide what aggressive needs to be our surgery.
It's a sigmoid column, sigmoidectomy in 2000.
Okay, left cancer. And molecular profile?
I don't remember the molecular profile. I know that the biliary tumor was KRAS wild type.
Okay. Okay, thank you. I think we can be a little bit conservative for surgery. Just we can have 2 millimeters probably of margin just with a resection of segment 1.
So if you want, I move on. This is, we planned after 4 weeks after the end of FOLFIRINOX, we planned a resection and we do a segmentectomy 1 extended, a little bit extended to the liver and to the portal vein because there is a terrible contact with the portal vein, and we decide to resect the portal vein with a cellulohepatic lymphadenectomy. Post-operative course was uneventful, and when you look to the pathology report, it's terrible because the MRI says the nodule is 20 millimeters diameter, and on the pathologist report, the tumor was 4 centimeter diameter, and with a low TRD4 post-treatment regression. The portal vein was negative, and the biliary limits of the resection were negative. The millimeter was 1 millimeter in cut margin, and the nodes are all negative. And now the patient is under FOLFOX post-operative.
Jean-Robert, did you resect the bile duct?
No.
Yes. This is the operative view here. Another view. Again, with the portal anastomosis here. This is the post-operative CT in November 2021. Sorry. This is the post-operative CT. It seemed good. Post-operative course was okay. Last follow-up, January 12, 22, by very recent follow-up. The patient was well, biology was normal, and the CT scan was considered as strictly normal. You can see here 3 images of the CT, post-operative CT, and the patient tolerated well the adjuvant chemo with FOLFOX, and this is in progress.
Thank you.
I do some bibliography for the staff. If you want to consult the papers, here are the major papers. And I was very interested by, this is my conclusion, it's a rare disease, case reports, small case series. Reportedly, the prevalence of intrabiliary metastasis by colorectal cancer range from 4 to 10%. This is in the paper of Nakamura. And the prognostic of the disease remains very unclear. It seems in the Japanese experience that the resection is considered to improve patient survival. But for my last conclusion, I show you this paper because it's a terrible paper. The patient had a synchronous biliary metastasis. She underwent an extended left hepatectomy, then a left colectomy, and she recurs immediately after the left colectomy. She recurs on the biliary tract. Here you can see the choleography showing a filling defect in the choledocogeginostomy here. And this is the autopsy of the patient with multiple endobiliary metastasis of colorectal carcinoma, with a very good study of immunohistochemie showing that there is no doubt is metastasis from colorectal adenocarcinoma. Thank you.
Thank you, Jean-Robert. Very interesting case. Laurence?
Just a comment, Jean-Robert. You performed a lot of chemotherapy, and particularly with the oxaliplatin with this patient. I'm surprised because it seems on the pathologic report that it doesn't work a lot. So I'm wondering, is it useful to do some adjuvant chemotherapy, and particularly with the oxaliplatin, because she had FOLFIRINOX, she had now FOLFOX 6/6. It's very aggressive for the patient, and it doesn't work a lot in that type of recurrence.
I know, Laurence, but this is the decision of the RCP. The oncologist said we have to do something. There is a huge debate about this. Personally, I think that when you look to the pathology report of the segment 1 resection and extended segment 1 resection, the mass was 4 centimeters. And I think that even FOLFIRINOX doesn't work a lot, despite a very good response on the imaging. Because when you see the MRI, I said it's fantastic, we can perform a good resection, but doubtful.
The CEA regress also, Jean-Robert?
Yes, completely normal.
Monsieur Bismuth?
Jean-Robert, first compliment for this nice case, not only well reported, but also well treated. So for me, I agree totally. Now I have a question. You present the case as recurrence intrabiliary metastasis of the first colorectal metastasis. And the second one, you say recurrence. So my question is it a recurrence of the intrabiliary metastasis, of a recurrence of the colon cancer, of the metastasis? Well, what you see at the end is there is a kind of I may say, facility, it could be in some patients, to have this intrabiliary metastasis, which is very rare. It could be a second metastasis of the cancer metastasis, you know.
Perhaps.
But
Gina, do you have
Oui.
anything to add?
Yeah, just one question. Initially, Jean-Robert, who did the follow-up after the first operation?
After the colonic resection,
Since you took care of the patient, yeah, and did the right hepatectomy, who did the follow-up?
us,
The surgeon,
yes.
not the oncologist or anything.
No, in my institution is the surgeon.
Thank you.
Right. Let's, Monsieur Bismuth, encore?
about the follow-up, it's true, we need to follow the patient for 10 years. I have one patient for recurrency at 14 years. So it's rare, of course, but we need to follow the patient after 10 years. But every year with a small, it could be only ultrasound and biological marker. But I think that my question is this, that sometimes I say when we report the result of treatment of colorectal liver metastasis, the figures stop at 5 years. The curves stop at 12 years. Then we are very lucky to have this follow-up at 5 years. But it's wrong. We must figure 10 years on the curve, and then we let open the follow-up. That means the evolution of the curve. But usually, when you have the question, people are very pleased to say, look, we have the survival at 5 years. It's okay.
Yeah, it would be an interesting point to develop as a presentation and to see what the evidence on follow-up between 5 and 10 years. I think Laurence should present that in one of the next meetings. Shall we move on? Jean-Robert, you have a second case, I gather.
No, because we have to give to you some news about the patient who was very debated in the staff, but Olivier had to move in Milan because his uncle is died, and we plan to present the news the next staff.
Right. Thank you very much. Who has, how many cases do we have to present, just to have an idea of the time?
Well, Pietro, I can tell you that we have Manuel Jaklic has a case. You have one or two, I think.
Yes, but one. But the total number of cases. Don't tell one by one.
So I would say, let me see, 5.
5 cases, right? So we are one.
I'm sorry, 6 cases.
6 cases, right? Then we've done one.
I can tell you from our part in Lisbon, we have 2 cases that need a solution that are not solved. But
right.
Of course.
We have a case that needs solution too.
Try again,
let's
Pietro.
say it again. Can you try again? Yes, try again.
Okay. You see now?
Yes.
Okay. Thank you. Okay, this is a very short presentation. I have the last 10 days a patient who arrived, is a male, who arrived to my consultation is a male, 46 years old. He just has arterial hypertension controlled. 10 years ago, he has a diagnostic of a right lobe liver hemangioma. And the doctor recommend to him do nothing. Then he arrives 1 week ago to my consultation for a right moderate abdominal pain. He has chronic nephropathy with creatinine of 1.2 and 1.3 in all of the exams, blood tests, normal transaminase, normal coagulogram, and no cholestasis. I just show you his images, his CT scan. Okay, here we have the first images. At the CT scan, we have this tumor located in segment 4, 5, and 8. Here, we just have the posterior right sector free of tumor. Another imaging, sagittal. Here we can see a very big hemangioma, and now we have another arterial injection of contrast. We have a very huge tumor. Here we can see probably segment 2 and 3 were also affected, and we continue to have a right posterior sector free of tumor. Here with necrosis and intratumoral shunts, arterial and portal shunts. Here another image. And then I could like to ask you what kind of treatment we can propose to this man. Voila, the options, and I would like to have your advice. We can try from the beginning with a liver transplantation. No, we can try just an enucleation of the myeloma, a kind of central hepatectomy with or without total vascular exclusion during the procedure. And 3, we can probably try to do some modality of 2-stage hepatectomy to try to have a better volume of the right posterior sector, because this man has 92 kilos, okay, of weight. Then probably the first imaging we have around 6 cc of right posterior sector to try to do extended hepatectomy. Probably he will have a problem in the postoperative follow-up after a big resection. Then I show you 3 possibilities, and I like to—
How many kilos has he got? Because we missed it.
94 kilos. And then his right posterior sector, I think, is too small to try to do in one time.
And the volume, you said 600, didn't you?
Yes, 600, 650, 100 around.
It's not too small.
Yes. Then he needs around 1,000 cc at least.
I think not, Raul. I think he needs less. It's 0.5.
But you always need to be more generous for this situation.
But if more generous means a transplant, I don't think it's more generous. But let's, Monsieur Bismuth and Hugo, answer to that.
Yes. Raul proposed to me to discuss this case 2 years ago, two days ago, and indeed I proposed the option 2. So I would like to defend the option 2, which is enucleation. And first point is, when an angioma is so large, it is centrally located in the liver. As you know, it's benign tumor, of course, and angioma arises on one point. There is one place of birth, some part in the middle part of the liver. Then it increases. it is not, of course, a malignant tumor. That means it's compressed the liver tissue. It's not invade the liver tissue. First conclusion, there is not decrease of size of the volume of the liver. You have the appearance of this. It is not true. This is why I propose, and I did that several times, and René, I know, he did several times this kind of operation. First, not to do arterial embolization, which is a bad solution. Why? For there will be collateral circulation, and this will complicate the excision of the nodule. But to go straight for the operation, but the first step of the operation, this is very important, is to clamp the vessel in the portal pedicle. That means, of course, the portal branch, it could be, this is to debate, the right or the left. We may try by the left and to see, or by the right and to see. And then what we observe, I may say always, not often, always, is a decrease of size of the angioma. Then we clamp the artery. And with the artery, we have a very important decrease of the angioma. And at that time, we must start the enucleation. And with the CUSA, I may say, in my experience, it was not difficult. Of course, if we have bleeding coming from the hepatic vein, at that time, but at the end, we may do a total vascular exclusion, but I don't think it is mandatory. May I ask René to comment this? Well, I think he has the same experience as me, but René, what do you think? Your microphone.
Yes, I would favor enucleation clearly, because I think in a benign disease we try to avoid a major hepatectomy and even more transplantation. For me, it would be terrible to make a transplantation for a benign disease. But coming back to, I would say, to the symptom of the patient, I will wonder if really this patient is symptomatic. You mean some pain and so on, but is it really symptomatic? Because it's usually there are the angioma of the left lobe who are symptomatic by the compression of the stomach or something like this, but rarely, I would say, in the right part or the central part, they are symptomatic. So what do you think? It's really a symptom related to the angioma for you?
This is the key question. Raoul?
Raoul?
Sorry?
The question was, do you feel really that this patient has a main pain in relation with the angioma?
No, it's not so important. It's not so important. It's a middle pain.
So I would not favor surgery in this patient, clearly.
May I add something? I start, but it was so difficult to follow the patient that I follow with Gina since more than 20 years, in order to have the follow-up more than 20 years of very large angioma that was not resected. Unfortunately, most of the file disappear. I'm sorry to say that to René. We could not find the dossier. But in one case, an angioma of 25 centimeters, 20 years before, and the patient answered to me, and she's perfect. And I asked to do a CT. I am waiting for the CT of the patient, but she has no symptom. 20 years follow-up of an angioma of 25 centimeters. That means the size is not indication of surgery, of treatment. But she has small pain, you see, small pain. Even small, it is important to consider. But what kind of pain? It could be a colopathy. I don't know.
Yes, he has a middle level pain. Is not so important, but he probably have one cries of pain each 2 days, something like that. But he's a young man, and then he wants to do more things in his life. He's a little bit limited of his quality of life. But yeah.
But you know, it's a benign disease. You may wait. You may wait 1, 2, 3 years. It's not a problem. The treatment will not change. The treatment will not change.
I would like to have your consensus. We can wait. Just wait.
It's Marcelo. Can you turn off your microphone, please?
Yes, I want to give my opinion. Can I make a remark? I have I don't say a large experience with this kind of benign disease with symptomatic hemangioma. And we have seen many papers from China that they treat this patient with arterial embolization with alcoholization. And it's very good. I know that Mr. Bismuth doesn't agree. I always talk against this kind of therapy, but I think in this case that the problem is just the pain. The treatment is very good. I have a good experience with this, and the patient get free of the pain without surgery. Does not decrease a lot, but in terms of size, you observe the regression. But the main objective, goal of the treatment is the relief of the pain. And I can show many cases of big, giant hemangioma that were treated with alcoholization, and the result is very good. That's what I want to say.
In this case, before alcoholization, I will propose to do acupuncture or to the Chinese. I may propose to the Chinese to do acupuncture.
He's meaning alcoholization in a glass.
Alcoholization, you see the volume of the angioma, how many liters of alcohol?
Just two observations. Raoul and Monsieur Bismuth said that firstly, but just go back to the literature and be pragmatic. Two observations. First of all, you showed us this imaging. First of all, he's a male, not a woman. Hemangioma are more frequent in female than male. That's the first step. Second step, when they progress in size, they progress in 4% of the population in the subgroup of patients. Number three, I don't know what was the initial follow-up of this patient. I don't know what's the initial image. You have to separate the group of patients who have a rapid progression in size and the one who stayed like 10 centimeter, what we call the giant hemangioma. That's the definition, is more than 5 centimeters. These ones can stay 20 years with that size. Then you have the group of hypergiant hemangioma, which are more than 9 or 10 centimeters. These ones can stay 20 years with the same size. So first question that you have to ask yourself, does the symptom related to the hemangioma, yes or no? Because in that case, it means that you have a growth in size within a lapse of time. That will tell you if there's an indication of treatment. Once you know that, because he's a male, I would follow him. I agree with René. I have to make sure that the symptoms are related. But I have to say that the location in the central of the liver, segment 4581, I cannot think that the pain is related. Normally, the patient with a central hemangioma, the first symptom that you will have will be cholestasis. I would have, because they compress the hepatic pedicle, then you will have biological proof of that. In that case, I'm not sure of that. In my opinion, I will follow him still. I wouldn't do anything. Then I want to make sure that the symptoms are related to that. then going back to the therapeutic approach, I agree, there's no need of a hepatic resection. Enucleation will be more than enough. But you have to make sure that the symptoms are related to that. And I'm surprised with that size that you don't have a cholestasis. There's no compression of hepatic pedicle. So I don't see what's the indication of surgical treatment at that point. That's my comment.
Another question: if we choose some kind of embolization, if we choose that, what kind of embolization you recommend? Arterial, portal?
I wouldn't. It will be the worst option for hemangioma. The worst for me.
Okay.
I wouldn't.
Can I add something, Pietro?
Ugo, yep.
I would say for this question, I think most of the discussion has already been raised, but I would say for this patient, first of all, we would have to see if the symptoms justify such a large operation, because even an enucleation might be a large and risky operation, and I think perhaps not. But in the case to opt for a surgery, I think there is little place for liver transplantation or even liver resection for hemangioma, and I would favor the approach that Professor Bismuth already said, to clamp the vessels, to do this under intermittent Pringle probably, and to perform only an enucleation. I think that using vascular exclusion, extracorporeal vascular exclusion, I think might be useful in some patients because it deprives some blood from the splenic circulation, and this helps. But in this case, I would probably just clamp the vessels and perform this under intermittent Pringle. Another thing I would like to add is that we have some patients with very large angiomas that were asymptomatic, and I don't recall, I might be wrong, but I don't recall having to operate them later in life. And we followed some of these patients. I followed them for more than 10 years.
Thank you.
I come back on what you said, and I come back on what I said also. That means thinking about the fact that we don't know the evolution and the progression of the angioma. First. Two, we are not sure the pain is in relation with the angioma. I will not propose today to do the resection that I proposed initially. I will be more conservative. I will wait. And in order to say a sentence, but this sentence is a little too extremist, too radicalist. We need to put the indication of surgery in angioma without taking in consideration the image. This is a little too radical, but we have to think about that. We are too impressed by the image, and we forgot the symptom. We forget the symptom.
Okay. Thank you very much.
Thank you very much. Shall we move on to the next case?
But we need to know the follow-up. Please, Raoul,
yes,
give us the follow-up of this patient in 10 years, please.
Okay, we will do that.
I would add only for hemangiomas, there is one danger, that somebody else will do the operation you don't do.
This is correct. Terrible.
Yeah. And so you have to really cling to the patient, to be conservative and be very supportive.
We cannot be preventive of the act of other surgeons. This is what you mean.
Yes. Right. Ugo, your case, then maybe we do our case.
Okay, thank you very much, Pietro. So first of all, a quick remark about the last case we presented of the lady that we wanted to perform an ALPS for cystadenocarcinoma. We did perform the ALPS. She's on the 2 of February. She's doing okay, still in the hospital due to ascites, wanting to go home. We don't let her because it's still not totally fine, but she's doing well. I have Pedro, which is one of the young surgeons of our department that has the case to present. And I ask him to share the screen.
Hello, do you hear me?
Yes.
Hello.
Go ahead, Pedro.
Okay.
You can see here, present now.
Yes. Okay.
This is a case where we need your help because we are in fact stuck with the options.
I'm having some problems sharing. So
Get out and get in again. Maybe it's better.
okay.
So we present our case meanwhile.
Okay.
Alessandra Cristaudi, if you can present our case.
Good morning. Can you see the screen?
Yes.
Okay. Actually, this is an ongoing case for which also we would like your advice. It's about a 53-year-old woman born in Brazil, but living in Switzerland since many years. And with no relevant past medical history, she's in good health. And in October, she presented with tiredness for a few weeks and an acute epigastric pain and fever. That's why she went in the emergency room. The laboratory tests were normal. She had a mild inflammatory syndrome, but liver tests were normal, no other findings. They performed an ultrasound, finding this kystic lesion next to the vena cava. It wasn't really clear if it was inside the liver or just beneath it. And that was a 6 centimeter mass measured on the first ultrasound. She came back home with a diagnosis of cholecystitis or cholangitis. They treated the fever with antibiotics, and she rapidly came better with the symptoms. And her family doctor go on with the investigation for this mass found on the ultrasound with the MRI, which was performed about a few weeks later, where we can see the cystic lesion in the T2 that was already smaller from the first ultrasound, little diffusion restriction.
The image is not the presentation is not progressing. Yeah.
Can you see it now?
Yeah.
Okay, then. So we see the cystic lesion, which is quite smaller than before. And this is the contrast MRI. Can you see that?
Yes, it's not moving yet. It's not, the film is not running. Yeah, it's now. It's frozen, unfortunately.
Maybe I can just, can you see the images now? They are just focused on the lesion.
Yeah, it's frozen on my screen. I don't know whether it's frozen on your screens as well.
Just try to go back. So there was no contrast uptake actually for this lesion. And this is the moment where the family doctor referred the patient to us. So what would be your diagnosis in this case?
So it's a 6 centimeters mass in segment 1 that starts big and spontaneously becomes smaller with no changes in liver function tests. Echinococcus serology was negative.
Yes, that's
because we thought Echinococcus emptying in the bile ducts but I've never seen, although I've seen Echinococcus without positive serology, I've never seen perforating in the bile duct without a positive serology.
No, MRCP.
Exactly. That what we propose to the patient, to do a CT scan, searching for calcification and that's the images of the CT scan, which show no calcification. The lesion is even smaller now. It's measured about 2.5 centimeters, and the patient still asymptomatic. So the patient didn't have any further symptom but the first epigastric pain episode. We performed a second serology to be sure that was not Echinococcus and that was negative. And that was our proposition to the patient, thinking about a biliary fistulization. And we proposed a surgical resection. The patient still well clinically, and she asked if it wasn't possible to wait some more time. So we waited some weeks and we performed another MRI at the end of January, just a few weeks ago. And at the last MRI, we hardly see the lesion, which is now measured less than 1 centimeter, still no contrast enhancement. And with a normal biliary tree on the MRI. Can you see the images?
No, not yet.
Unfortunately, it's still on the screen for me. Yeah, Prashant, the same for me. When we prepared the presentation, it was beautifully scrolling, but now on this program, it does not scroll, unfortunately.
Alessandro, did you perform the scan with hepatobiliary contrasts?
Yes, it was. There was no contrast uptake in any phase on both MRI we performed. So we would like to ask, what would you be your differential diagnosis, and what would you do with this woman, which is asymptomatic? She has a regressing lesion, but without any precise diagnosis.
This is very disturbing. For you present a case with a patient without symptoms and with a lesion which is she decreases in size. The nodule decreases. The lesion, the cyst decreases in size with time. This is correct.
Yes,
exactly.
She started from 6 centimeters to less than 1 centimeter in 2 months.
Without antibiotics?
She had 1 week antibiotic at the beginning of the history in October.
Because it could have been an abscess.
Yes.
What do you think?
Exactly.
This could be a pseudo-inflammatory tumor.
Yes.
After an abscess.
Yes.
Before doing surgery, you don't think you may put a needle inside?
Exactement.
We didn't want to
ask.
Another question for hemangiomas serology. Was it performed? Maybe hemangiostics test. Can you hear me?
Surendra, yes.
For amoeba, a serology for amoeba, maybe a liver amoebiasis.
I will agree with Rene that if you look at the evolution of the whole lesion, it is subsiding. You gave the antibiotic in the beginning. She had some fever, some pain, and the lesion was seen, and it is resolving. So why do anything at this stage? Wait for 1 more month and then see the imaging. It may disappear if it is an infective.
It has not been performed research for amoeba.
It was not, the aspect was not amoeba at all.
Yeah. It doesn't look like amoebic abscess. Without any treatment, it is resolving just with a course of antibiotics. It doesn't seem to be amoebic.
Please go on. For we are blocked today. Go on before the lesion disappears totally.
Well, so in the end, we will add the amoeba serology, but the consensus, it seems to be that we should wait until it disappears completely. So we can't do anything.
Why is that issue?
Wise decision.
It's all about simplicity, Jekyll. There you are.
But it was a very strange case. So we thought well worth presenting to you.
Okay, Pietro, I think we are ready to present when you want.
Good.
This is more a question for the surgeon than for the patient. Pietro, you understand what I said? I said this is more, the patient is more a problem for the surgeon than for the patient.
Yes, absolutely. The diagnosis.
You need to know what is the
Yes, we will send. We have a very good infectious disease specialist, and she will probably think at other things that we may not talk about. And we'll get back to you if she comes up with something intelligent. Thank you, Alessandra. So, Ugo.
Yes, so I asked Pedro to start. And I remember, so this is an unsolved case that has been troubling us, and we need your help.
Can you see my presentation?
Yes.
Yes. Okay. First of all, I would like to thank Professor Ugo for inviting me to present this case. So today I bring you a 73-year-old female with a past medical.
Pedro, can you enlarge the screen?
Yes, I can.
For presentation.
Only for presentation.
In presentation mode, you see?
Yeah, but can't you see like this in presentation mode? No.
No.
Okay, so let's do it like this.
You have this button here to present.
Can you see now? No.
Okay, but it's okay.
Is it better?
Yes, it's better.
Okay. So as I was telling you, we have a 73-year-old female with a past medical history of hypertension, tuberculosis. She also has a hepatitis B since 1992, and her viral load was always very low. She never did any treatment for this condition. And since May 2021, she reported a weight loss of about 23%, and she also referred difficulty in swallowing. So her doctor performed on her a blood test, which came fairly negative, except for an elevation of the alpha-fetoprotein, which was 53. And he also ordered an upper endoscopy, which was revealed a non-specific gastritis, and the search for Helicobacter pylori was negative. Due to this, he ordered an abdominal CT scan, which showed diffuse heterogeneity in the segment 4 and 8 of the liver. But this was also still very unspecific, so he opted for an MRI. So this is the first MRI that I have to show you today. I don't know if this will run or not. Let me see. Can you see the images rolling?
Yes. Yes.
Okay, very well. So what I present you is a mass of about 6 centimeters in the liver. And I have this sequence, and I have another one to show you that it's this one. And in this one, we can see a thrombosis of the middle hepatic vein, right hepatic vein, and we see also that the mass touches the left hepatic vein and the inferior vena cava. And we do have also a contrast, a specific sequence for the liver. And there is the mask is highly enhanced with contrast. And all of this together is highly suggestive of a cholangiocarcinoma. So just to sum up, we have this 6-centimeter lesion, highly suggestive of cholangiocarcinoma with involvement of important vascular structures and also a lymph node enlargement. So our first question to you is, what would you do next?
I would do two things. I would do a liver biopsy first. You need to know what's about the underlying liver to make sure it's not a chronic hepatitis or anything. Second, this imaging alone is not enough for me to make sure that it's a cholangio, because it might be an HCC also. So I need to do a liver tumor biopsy. But before that, I need to know if the liver is normal or not.
So
before deciding any surgical treatment, I need more information.
Okay. Just one thing to add, assuming that we don't have all the images, but even assuming that it was a cholangio, a careful review of the exams show that there was an infiltration of both the portal vein, the right and the left, and the 3 hepatic veins, and we consider this unresectable without the total hepatectomy, because actually we didn't see any kind of vascular particle that we could preserve. This is not shown in the images.
I agree, but you may think about
yes,
downstage.
But of course, yes. Any other comments?
Downstaging also.
So if I could say something, Hugo, I had a comment that we've seen that the lesion obviously is not upfront resectable. There's no way you would be able to resect it. Have you ruled out extrahepatic disease in this patient?
Yes, yes.
Is there nothing else outside? Because they are too close to the vascular structures. I would definitely like to rule out extrahepatic disease first.
Yes.
You have ruled out. There is no extrahepatic disease. We have a PET scan, right?
We don't have a PET scan. That is the thing we don't have. But we have the extrahepatic extent of the disease that shows nothing.
Okay. I would still, if at all, you have the facility, I would still do a PET in these cases, because
that is also reviewed, yes.
Yeah. So I think we should. And obviously, I think in addition to the MR, a combination of 2 modalities for better definition of the tumor is one. I wouldn't really think that biopsying this tumor is neither going to be very easy, nor, of course, when you do if you want to do a neoadjuvant, or you want to do a downstaging, or you want to do a chemo, you will have to have tissue diagnosis. But at the same time, I'm not sure whether this is going to be a very easy type of biopsy from the tumor. And what about the other tumor markers? Do we have, because I missed out on one or two.
Prashant, why do you say it's not an easy biopsy? Because I think it isn't an easy biopsy there.
I'm sorry, Pietro, but I did not really, because what I could see is that the tumor is concentrated at the ostia and close to the portal vein, right?
No.
I couldn't get the axial imaging.
Good parenchyma before it, when you can get a good biopsy of that, and I think a biopsy would be mandatory for this patient, because
you will need a biopsy before you do anything.
Some downstaging, and there are new treatments, even for cholangiocarcinomas, that can downstage this patient, and you may consider all sorts of.
I completely agree with you. For any sort of new downstaging, any sort of new adjuvant therapy, you will require a biopsy. The reason I said that was going through normal liver tissue to reach this particular tumor. So I didn't have the axial, I couldn't see the axial ones too well, the axial and the flow of the sequences. You would be able to tell us anyways if this is a tumor which there is an easy access through the parenchyma to get into the tumor.
Prashant, it is mandatory to do a biopsy.
Yes, I agree with you. Yeah, I agree with you.
And the second reason, as I agreed with Pietro, yes, because you can downstage, okay. And thirdly, let's say you consider to do a transplant, as Hugo said. What type of immunosuppressant are you going to give? Is it going to be sirolimus, everolimus? You know, things are changing, even in the medical treatment after transplant. So when you consider this, there is the step of downstaging the tumor. Second, even if I'm going to transplant, I want to know what type of immunosuppressant I'm going to give to this patient. So
for me, Gina, that would not be
biopsy.
Yeah, we agree on that. René has raised his hand.
Yes, just I fully agree on the necessity of a biopsy of the normal and the tumoral liver. But my point is that it could be a hepatocholangiocarcinoma because alpha fetoprotein is increased. And anyway, this biopsy will allow to do, I would not go to surgery first because of the complexity of it. Possibly we may indicate either chemotherapy or radioembolization, because radioembolization for such type of tumor is increasingly efficient and so on, before considering surgery.
I may ask Pedro to continue because this next slide is about this.
Yeah. So can you all see? So we discussed this patient on our multidisciplinary meeting, and we did do a liver biopsy with 2 samples. And the first liver biopsy that we ran only showed a mononuclear inflammatory cell infiltrate. So this was not very elusive for us. So we decided on a second biopsy. And on this second time, we did also have this cell infiltrate and also non-necrotic granulomas. So we didn't have any neoplastic cells, nothing else. All of the stains that we ran were negative. So this was still a little bit, we didn't know what was going on. So we ordered some blood more tests, and we extended this and tried to figure out if there was some sort of disease, infiltrative hepatic disease of infectious etiology. Because of that, we ran all the virus. And the only thing that we got positive so far was these Coxiella burnetii antibodies that were positive. We discussed it with our pathologist, and the slides are not typical of a Coxiella infection. So the patient doesn't have any symptoms that make us think of that. So because the liver biopsies didn't really...
Okay, Pedro, don't go further because I think we need to discuss this.
Okay.
I wanted to add 2 things. The first time the normal biopsy of the non-tumoral liver was normal, and you had these inflammatory infiltrates, and we asked our team of radiologists that we have a lot of confidence in them, and it was the chief of the radiologists that performed this biopsy, and she assured me that it was a biopsy that was on the spot. And then this result came, and we asked, okay, we have to repeat the biopsy. So she did the biopsy again. She assured that she hit the tumor twice, and the result is still this. There's also a report of eventual granulomatous hepatitis. Okay, Pedro, can you continue?
Yeah, I continue. Okay. Taking into consideration these 2 biopsies, we ordered another MRI. And in this one, we still see the same thing, but the tumor has grown. In 1 month, it has grown. And I would also like to point that now we can see that there is a compromise of the posterior segments that are dependent on the right portal vein. We still do have that liver contrast sequence that shows that it is highly enhanced when applying contrast and highly suggestive of cholangiocarcinoma. So this is where we stand, and this is why we bring you this case.
So I would say she has strong constitutional symptoms with more than 20 kilos weight loss. This tumor is enlarging. It has thrombosed the middle and right hepatic veins also. And the biopsies continue to be negative. But frankly, we are not sure that we are not in the presence of a malignant progressing lesion. Gene has no sound.
With alpha fetoprotein of 99, right?
Yes.
That's the only tumor marker which is raised.
Yes.
Yeah.
I will start with the probably embolization, chemoembolization or radioembolization to try to downstage.
And you all believe this might be a malignant tumor because it's what it looks like, regardless of biopsies.
Yeah, I would need a new biopsy.
Me too.
And I would, if you don't have the new biopsy with the radiologist, you don't give up until you have a biopsy. You
That's
open
exactly
the patient, you have a biopsy.
what the patient is going to do next week is a biopsy with 4 samples of the tumor. That's what we ordered.
Left and right.
Yes, but still we wanted your input.
Left and right by multiple biopsy.
Prashant has raised his hand.
Yeah, so this is, we have had experience with 2 or 3 of such tumors, which are very close. And that's the reason I raised this point about getting a representative, proper biopsy from this particular lesion. So my intention was not to say don't biopsy. My intention was to say that in these patients, I have had 2 or 3 patients where it looks typically very malignant. It is spreading very rapidly. And still every biopsy says it's negative. And my IR person says that I've got good tissue. So what I was suggesting was that is it possible or would it be better if the access could be better in these patients if they were to try a TJLB, a transjugular approach. And if your intervention radiologist feels that he can go closer to the tumor with little amount of liver tissue in between and hit the tumor better. If you have a space in between the IVC or the right hepatic vein and the tumor, if there is enough of parenchyma, you may get a better representative sample. So that's just a suggestion. So I think that the other thing that would help you in the PET scan, Hugo, is sometimes the characteristic of the tumor on the PET scan. Intrahepatic cholangiocarcinoma may light up in a particular manner, whereas HCC may be slightly different. And this could be a mix of HCC and intrahepatic, especially since you have hepatitis B positive in this case. So viral marker is positive. So you may have a tumor without cirrhosis. So it could be an HCC hepatocholangio. Just to
just a comment, just to say that at least in our center, I think the quality of the transjugular biopsies is not the same. The amount of tissue that you have is much less and sometimes more fragmented. And I think it's perhaps more difficult to obtain a result, but still.
Yeah, Surendra?
Hugo, is there any peripheral eosinophilia in this patient?
Eosinophilia, I don't think so. We'll have to check, but I'm not sure. Pedro, can you answer?
We don't.
The reason I'm asking because one of the differential diagnoses, as you're saying, could it be infective? Looking at the biopsy. And yes, tuberculosis is the one possibility. The other thing is some parasitic infestations. So yes, of course, the biopsy will be important, the proper biopsy.
Right. No more hands raised. Hugo, are you satisfied for the management now?
Yes, I think we all agree that we need more biopsies. And I think that's what we have to wait. I'll keep you updated on this case.
Keep us updated.
Yes. Thank you.
Good. Next case.
René has a case to present before leaving. René is here.
Yes. Can I present the case now? Can I share the screen? So, So I think this one. Do you see my screen or not?
Yes.
Because it's not so clear for me. I don't see it very clearly. You see my screen very clearly?
Very much so. Février 2019, dysphagie amaigrissement.
Yes, but for me it's totally dark. I don't know why. So I try again, sorry. I try again. Okay, anyway, I don't know, understand why it is so.
Try to make a presentation mode and not just a PowerPoint mode. If you click on the screen on the right, as if you were presenting.
So I put now une fenêtre, un onglet, l'intégralité de votre écran. I don't know. So I try to make, if I do this, no, I don't see, let me see. Do you see my screen now or not?
Non. Clique sur présenter maintenant et après tu mets mode présentation.
Présenter maintenant.
We may ask our web experts to migrate to Zoom.
Yes, this is clearly would be probably the best, because if not,
yes,
it's so simple.
A Zoom webinar, and we can record it and put it on the website afterwards.
Présenter maintenant. Where is présenter maintenant?
À côté de la main, après tu as le petit, voilà. Voilà.
Yes, but
voilà, là on voit. Là on voit tout, hein, René.
Okay, so I will try, but I have no control of my slide. This is a problem. So you see my slide, but I have no possibility of. So when I change, okay. So I will do my presentation anyway. So I'm sorry, you see my screen?
Yes.
Okay, so I'm sorry, the screen, the slide are in French, but I will comment, of course, in English. And so it's a patient male, 68 years. You have the size and age and so on. No past medical history, very significant. And the patient has in February 2019, dysphagia and weight loss of 22 kilo. And he had, of course, an endoscopy, and the endoscopy makes the diagnosis of a double, I would say, localization of a tumor in the esophagus at 40 and 45 centimeter. So double localization, the CEA was 11. Histology was that of adenocarcinoma of the esophagus, and the immunohistochemistry was HER positive, for Herceptin, HER positive. And so the patient had, of course, a checkup for seeing if extrahepatic disease was present. And you have here, the patient was explored.
We don't have anything. We are still on the same first slide, René.
Ah, so I don't know what to do. So now it moves.
So although maybe you can just move, just use the arrow to go to the next slide. We see the second slide now. Just use the arrow to the next slide.
Okay. And
yes, now we see the CT.
Now this is a CT. This patient was explored outside the Hepatobiliary Center. And so I don't know why they did CT without injection, but you can see the major involvement of the liver by metastasis, bilateral metastasis. And he had also a PET-CT FDG without extrahepatic localization. And what to do for this patient? I would say he had a cancer of the esophagus with dysphagia, and everybody would agree on the fact that we should do probably chemotherapy. This patient has a chemotherapy with 5-FU, cisplatin, and Herceptin because HER2 positive. And after, I would say, 10 courses of chemotherapy, there was a fantastic improvement of the general status, a good biological response with CEA coming to 3, normalization. At the endoscopy, the gastroenterologist didn't see anymore the 2 tumor in the esophagus. He did a biopsy without tumoral lesion. And I show you the new imaging 8 months after the beginning of the chemotherapy. This was the initial tumor you see in the liver. You see the screen? No problem?
Yes, no problem.
And so very good decrease in size of the hepatic tumor, and the PET-CT confirm, I would say, the size reduction of the bilateral liver metastasis. And so, in summary, 68 years old, male, double localization of adenocarcinoma with a good response to chemo. And so, what would you propose to this patient at that stage? Would you propose to continue chemo, to make a surgery of the primary lesion of the liver, combine? Would you stop treatment, stop and go? Because we don't see any more, I would say, evidence of active tumor. And so I don't know if some of you want to make a comment on what he would propose to this patient. Yes.
The first question, you said that the endoscopy has shown a total disappearance of the esophagus lesion.
Yes.
Is that? And there were multiple liver mets on the liver, right? My first question, are we sure these liver mets were related to the esophagus?
No biopsy was done, but as these lesions were discovered synchronously with the double localization in the esophagus, it was very likely that there are metastases from the esophagus, but no biopsy was done.
And the chest, he doesn't have maybe breast?
No.
Because that was my first thought because of HER2 positive, and he responded to Herceptin. So I just wanted to make sure that it wasn't related to esophagus. But he responded to chemotherapy.
Yes,
so
he's a male, so breast cancer in a male, it exists, but it's so rare. No problem with the breast.
I'm not sure about taking off the whole esophagus if you said that there's no more lesion. So I don't know if we have to remove the esophagus at that stage. Mm-hmm. For the liver, though, the surgery can be minimal because it responded very well to chemotherapy.
Mm-hmm. Everybody agree on the minimal, I would say, on a limited hepatectomy?
Yeah.
Mm-hmm.
And at the same time, I will have the clear.
Pietro, your micro.
Sorry, Rashad, Jean-Robert.
Yes, can I make a suggestion, please?
Yes.
I think at this stage, I would repeat the PET scan just to make sure that we're only dealing with liver lesion only. There isn't anything in the esophagus. That's to complete the staging after the treatment, which he had a very good result, and take it from there.
Okay, but this was, I show you, this was the PET-CT after chemotherapy.
Repeated.
So, sorry, Was there any lesion in the esophagus or anywhere else? Only in the liver?
Only in the liver. No uptake in the esophagus, or neither in the lymph node.
Right. So we're dealing actually with liver disease only, right?
Apparently.
Visible, at least.
Visible.
Prashant.
Professor, although I just wanted to ask you a question, because when we make this particular decision, we are trying to corroborate this to another type of tumor. For example, we have evidence today that in colorectal liver metastasis, you could go ahead and take a liver first approach. But in esophagus metastasis, along with tumor now in the liver, are we at the stage where we have enough evidence to say that we can tackle only the liver without tackling the esophagus? I think not. And that's why I do not think that this could be limited to only a liver first approach without tackling the esophagus, because I think the upper GI malignancies would probably behave a little bit differently. So I'm not sure if at this stage itself, we can straight away go ahead, whether it is too early, whether it is enough time to go ahead with liver resection. I'm not sure. And again, I'm not sure whether we can leave the esophagus behind in a esophageal cancer with liver mets.
Yeah. Thank you, Prashant. Jean-Robert. Jean-Robert, we can't hear you.
Yes, René, a few years ago, you report the results of liver resection in non-colorectal metastasis cancer. So you know very well the results.
I will present it if you want, because it's part of my presentation.
And
later. Okay. We have John.
I'll just sort of just quickly say, you know, in these situations, we have upper GI mets to the liver. We'd be prepared to treat the liver only sort of limited oligometastatic disease, and after a long period of declaration of the biology of this tumor. So limited disease, biology declared, then you'd be prepared. I'm not sure this case qualifies because it's more disease than I would have thought that we could do. And I think the follow is quite short right now. So I would say continue with the chemotherapy.
Okay, so can I just...
At least you responded very well. René, carry on.
Okay.
I agree with John.
So a big debate was present in our tumor board meeting. And indeed, what we report with Laurence at the French Congress of Surgery was a national survey about non-colorectal liver metastasis. And we come to the fact that mainly for squamous cell esophageal carcinoma, there was very, very few cases of metastasis, and a lot of them present a recurrence. And from 8 cases, we recruited at that time only 1 survivor at 3 years and no survivor at 5 years. And so because of this very limited experience with not encouraging result, we recommend at that time not to consider any liver surgery for liver metastasis from esophageal cancer. And coming back, I would say the prognostic model that we propose after this big survey, we had 3 types of factors, 3 factors with 2 possibilities, yes or no, 2 factors with 3 possibilities, and 1 factor with 4 possibilities. But anyway, this patient should have, and I will come back to that, a major hepatectomy. He was aged more than 60. He has an interval between the disease, I would say, and the metastasis less than 12 months. And between all the possibility of primary, he has 1 point. And so the total number of points of bad prognostic factor come to the fact that this patient had, in fact, if I remember well, 6 points. And 6 points mean that he has an intermediate risk, I would say, in terms of recurrence. and the survival could be estimated at 5 years of 33%. Of course, this is a prognostic model. Of course, this means that we will care at the same time the primary and the secondary. And another study come to our discussion. It is a study, a French study, recruiting from 17 centers, 54 adenocarcinoma of the esophagus with liver metastasis, isolated liver metastasis. And there were 23 patients treated by chemotherapy, 31 treated by RFA or by surgery, and case mix study was done comparing the patient with ablation or surgery or chemotherapy alone. And finally, you can see here the survival curve of surgery with radio or radiofrequency and the curve of chemotherapy alone, coming to suggest, only to suggest, it is a retrospective, that treating locally liver metastasis of adenocarcinoma of the esophagus could lead to a better survival. You see my screen? Okay, so another study was done very briefly to something that you know. The response to chemotherapy in non-colorectal liver metastasis before surgery is absolutely mandatory to obtain a good result. And you have here the patient who responded, the patient who didn't respond. And so, because of that, we consider finally at the tumor board the possibility of liver surgery first, knowing that the double primary will still be in place. But before taking the decision, and the decision was to realize the hepatectomy first, the decision is what type of hepatectomy to be done. Minimal, yes, but when you see, I would say, the size of the initial metastasis, here, to do a limited hepatectomy appeared difficult because this was a contact of the portal bifurcation. The right hepatic vein was involved by the tumor. And so we come to the conclusion that a right hepatectomy was difficult to be avoided. And so we did a volumetry. The decision was to do a right hepatectomy enlarged to segment 4B because of this lesion, and to do a partial hepatectomy on the left. So it was not a simple procedure. And we did a volumetry, and at the volumetry, the ratio between the future remnant and the body weight was 0.5%, just at the limit. And the remnant liver was 32% of the total functional liver. So in view of this result, in view of the marginal indication of this patient, would you proceed to the right extended hepatectomy up front? No. This is my question.
No.
Go ahead, Gina, please.
Personally, did you ask why not doing a two-step? Starting with the left resection of the small lesion in the left lobe?
It's sure that if we can do in one step, I always prefer to do all in one step.
Continue.
You know, two step in addition for marginal indication like this and so on. This patient will have to be treated with a post-op chemotherapy. We will have to deal with the esophageal primary, and to enter into a two-stage hepatectomy, it's a little bit more complex. Knowing that by doing a right extended two-segment 4B hepatectomy, it's possible to remove all the lesion.
René,
yes.
René, I would say even although the volume looks sufficient, I think 0.5 of ratio is low, and I would definitely try to do a port of an embolization. And as you say, limit this to one operation.
Yes, and this was our choice. This was our choice because I was aware of the marginality of the indication, and so we should be, as much as possible, safe for doing hepatectomy in this type of patient. And so we did a right portal embolization, and after this, we come to a more secure percentage of remnant liver, also a more safe ratio. And so the patient has an operation at 5 weeks from the embolization. There was no location, extrahepatic localization. We confirmed the previous hepatic lesion. He had a right hepatectomy enlarged to segment 4B with a partial hepatectomy on the left. And the post-operative course was uneventful. And you can see that at the CT scan at day 5, there was a small collection here, but without any symptoms. And this is the pathological findings, right hepatectomy, 4 metastases, 40 millimeter, with a complete pathological response. The resection of segment 3, part of segment 3, complete pathological response. And the lymphadenectomy of the celiac and the left part of the pedicle, 6 lymph nodes, normal without any tumor. So favorable pathological findings. And so come after this, the decision of what to do for the primary. To make a follow-up, to do chemo, to do radiotherapy, to go for surgery.
What is the primary?
The primary?
The exact nature. Ouais.
At 40 and 45 centimeter adenocarcinoma.
I would, if I raise my hand, it's a disease that I know so little that I would ask an expert on esophageal tumors to guide me on that. Because now the problem is his, a tumor that has responded to chemotherapy so well, for us, it's a rare case, but for him, it's not a rare case.
Mm-hmm. And we used to ask for expert, I would say, GI surgeon for that. And we decided to continue chemotherapy by 5-FU cisplatin herceptin. We redo endoscopy and a new biopsy of the previous site of lesion, and no tumor was discovered at the histology. And with the oncologists of this patient, which was outside, I would say, our center, we decided to do a radiotherapy in a way to secure, rather than surgery, which would be very risky in this patient, because it's, of course, an extensive surgery for no tumor detectable. We prefer finally to do radiotherapy. And we do at the same time chemotherapy to potentialize the radiotherapy with FOLFOX cure. And so this is the evolution at 3 years from the diagnosis and more than 2 years from the hepatectomy. The patient, I have seen the patient 1 month ago, less than 1 month ago. He's asymptomatic. He has a totally normal life. The CA is normal. He has had a new time endoscopy, upper endoscopy with new biopsy, and they found only stigmata of radiotherapy, but without any recurrence. And all the imaging, I would say, modalities are normal without any recurrence in this patient. So these summarize the example of this patient, 68, double localization, adenocarcinoma, but HER positive. Possibly the fact that he is HER positive make him, I would say, a better prognosis. He had an excellent response to chemo. We did a hepatectomy. we control this without any recurrence. And we have had a conservative approach for the primary. And up to now, we should be very careful without a recurrence at 3 years. And so the take-home message, in my view, is that, in fact, the contraindication to surgery of liver metastasis from esophageal cancer may be revisited in selected patients, very strongly responders to systemic chemotherapy, at the condition of an acceptable operative risk, of course, on a multidisciplinary setting, and with the patient agreement, because I said to the patient, we are outside the line. Usually, we don't perform surgery in the case like you. Would you accept to take the risk? And the patient said me, yes, I would accept to do it. And of course, what may be questionable in our case is not to have done any surgical resection of the primary, because indeed, even if no tumor is available endoscopically, one may assume that some residual cells could exist still. It has not been the case up to now. So thank you.
It's beautiful, beautiful.
René, bravo, but you confirmed one thing. I remember that 20 years ago, the main difference between these type of liver mets of non-colorectal cancer, the major prognostic factor is really the response to chemo that might create this subgroup of patients that might benefit from surgery.
Yes, you say me bravo, but nobody say, has the surgery been useful in these patients? We can auto-criticize our attitude.
Now, at least
may say
you don't know, René.
Yes.
The question, it may not have been useful, but you made it not harmful. And so I would be happy with that.
Yes.
René, we must say it is something extraordinary. We may compliment you for the courage and also the continuity in the thinking. And this is I think if we may repeat this case, it is an opening. You treat a cancer of the esophagus by an hepatectomy alone, which is fantastic. I am a little afraid it exists. At the time you must publish in the Bible, where usually we publish the miracle. But I think it is not. It is a new opening, and this is very interesting. Very interesting.
Just to add a comment, I have had recently another case, the same, with one localization. It was a squamous carcinoma with diffuse involvement of the liver. We did a liver first, right hepatectomy. He responded first very well to chemo. So liver first, then chemo, and then a Lewis-Santi esophagectomy by specialized GI surgeon. And the patient is now alive without recurrence at 1.5 years. So we should be still very, very careful. But it is very surprising to me that now we are coming more and more to what was in the past contraindication to liver surgery.
But really, this is an illustration of the benefit of the association. Well, if you think about the surgeon alone is finished. And this is an excellent illustration of the need to have the association at the same level of the neoadjuvant treatment and the surgery. And this is an exemplary case. Pietro, it is 4 o'clock. Do you think, I need you to, Pietro, as the chairman of session, now to do a summary of the new message of this session. What we learned today.
Well, I don't know whether we learned something new as a principle, because these were the principles you always advocated. I mean, look for what makes the disease exceptional in your patient, and you will find the window that nobody else has found. So the pattern,
This is
It's
about
not
this case,
changing.
but for all the session.
Yeah, for all the session,
I mean,
I think it's, yeah.
First is we must give the results not at 5 years, but at 10 years.
Yes.
One message. Second message, to cure the patient before he's cured by himself.
We have to rush to operate patients before they heal themselves. Yes.
Yeah.
But this does not apply for giant hemangiomas.
Okay.
Giant hemangiomas, we have to wait.
Now, for giant, I give a message for giant hemangioma. I say for hemangioma, take the indication, but not without seeing the image.
Yes.
That means only on the symptom. Don't
yes,
be influenced.
That's another important
Don't
message.
be influenced.
I agree.
Just a question about hemangioma, a naive question, because I'm far from to be an expert. Why you don't use beta blocker during the follow-up? Because in the children, a few years ago, a fantastic paper in the New England Journal avait attiré mon attention. They have a major response with beta blocker. And perhaps beta blocker is better than embolization.
Yeah.
It's very interesting because the patient have hypertension also. We can try to do that.
Right. That very interesting session indeed.
Now, if we finish now, I would like to speak about New York. And the first thing about this meeting, New York must be a place where we, Compagnons, we will confront with the American surgeon. And for our session clinical case, some case presented today and also in the previous staff will be very important to confront the American surgeon. For instance, the case of the angioma, giant, super giant hemangioma, I am quite sure it is present without our proposal. They will presented the case, we will see what do you propose to do?
Okay.
No indication of our thinking. I am quite sure that the American surgeon will propose transplantation. Quite sure. And I think it is good to confront them. The case of Henri, fascinating to present to American surgeon. We will see what they say. So many cases coming from our experience must be confronted with the American surgeon. So I will privilege in the selection of case to present the one who are not well.
Micro.
Yeah.
And René, I think, present the case. It's fantastic. Raoul,
in New York, I will not be able to be with you because of many meetings in relation. But I will join you, I think, around 5. So
okay.
I don't know. So, around 5, it will be good.
Okay. We let your case at 5, no problem.
Okay.
And
we will stay all there.
We have to prepare. We have to prepare New York for not usual congress, but the special congress. The first time, not the first time, second time we are in New York, but to confront with the HPBA surgeon, which is good. As you know, many are liver transplant only, oncological surgeon only, not so nuanced that we are in the indication. What do you think, Pietro and Hugo and Gina about this? Hugo, I propose that we come back to the selection of the case to take first the case which will be very exciting for discussion in this view.
In this setting, yes.
I agree.
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 We must answer to Hugo. He sent the list of all the KTRs, and please answer to him to be sure. But we have to give the program to Jean, and Jean will add the American surgeon to discuss. So please answer to Hugo. Look at the list. It's in 1 month now, so we are in rush.
Just one thing, some people might have trouble editing the Excel sheet, so send me an email for me to authorize. Sometimes in some cases it is necessary to do that.
But Hugo, we need to finish this list this week. We have only 3 weeks after to send to Jean-Raymond. I think he needs to print apart, but it is too late to print in the book of EHPB. And I discussed also one thing with Jean, and we need to do that I know that some of us are not going to the EHPBA meeting, only to our session. Our session will take place in the Hilton Hotel, in the place of the meeting. I don't want that they have to pay the total fee of EHPBA only for coming to our meeting. You understand that?
Mm-hmm. Yes.
We are going to the meeting, so for us we pay, okay. But some of us are not obliged to do that. I will speak with John to put our meeting apart, only for this kind of expenses. Please, if you have think about the New York meeting, it is important for the companion to appear strong among the EHPBA surgeons. We have only this day. This day must be excellent. You agree?
Okay.
I think Rashad wanted to say something.
Yes. Would there be any chance to present virtually in case we cannot travel?
Yes.
Okay,
yes.
that's fine.
Yes, of course. We say the meeting will be hybrid. I asked this to Jean. I don't know the answer for his integrated EHPB meeting, but I am quite sure that also EHPB meeting will be hybrid.
It's hybrid.
At that time,
hybrid.
At that time, we need to, and sure, if you don't come, it's not only for you, but for all those that can come, we know and we'll take a place to put you. We have the program, and you must say if it is good for you. Of course, we will adapt for the people in the West and the East to not to be at the bad time in the meeting. Okay. We do like that. Pietro, you conclude. You are the chairman.
Well, thank you very much to everybody. The fourth message is that the next time we'll try a Zoom, which works better for sharing screens. So I will liaise with our webmasters for that. And it's always a great pleasure to see you all.
Is Marcelo and Daniel. Daniel is here? No, Marcelo.
Yes, I am here.
Yeah, Daniel.
Marcelo is always also here. Usually we use the Google Meet because it's what our university affords, but I think we could all discuss to find a way to use Zoom. Maybe it would be easier for to use.
We listen nothing. We listen nothing. What you say?
Say it again, because we didn't understand. Daniel?
Okay, Marcelo then. Marcelo.
Yes, this is a program of our university. This is Google Meeting is free for us in our university. So you can use it without problem. You don't have access to another way, another program.
Yes, but you can, if somebody else gives you a Zoom platform, you can go on it.
Okay. Anyway, our next stop is New York.
Yes. So we have time to change.
Exactly. So
and it will be a pleasure to see you. Thank you very much, everybody.
So we see us in New York.
And
And thank you. Thank you,
Merci.
for organizing this meeting. And
Thank you very much.
our chairman.
Thank you so much.
thank you. Bye-bye.
Thanks, Pietro.
Bye.
Bye-bye.
Thank you all.
And thanks to Hélène for the music.
Yes, but since my earphones are cancelled, so I couldn't hear it. It's only you could hear it.
Bye-bye.
Take care.